The human stomach is a vital organ in the digestive system, responsible for the mechanical and chemical breakdown of food. It serves as a dynamic reservoir where food is temporarily stored, mixed with gastric secretions, and then delivered in controlled amounts to the small intestine. Structurally and functionally complex, the stomach's anatomy can be classified into external and internal features, each contributing uniquely to its digestive role. External anatomy of the stomach. Location and position. The stomach is located in the upper left quadrant of the abdominal cavity, predominantly in the epigastric, left hypochondriac, and umbilical regions. It lies just inferior to the diaphragm and posterior to the left lobe of the liver. In normal adults, the stomach occupies a J-shaped position, but this shape may vary depending on body habitus and stomach contents. Gross anatomical divisions. Externally, the stomach is divided into four major regions: the cardia, fundus, body, and pylorus. The cardia is the area surrounding the opening of the esophagus into the stomach. It contains the lower esophageal sphincter, LES, which serves as a critical barrier to prevent the reflux of acidic gastric contents into the esophagus, thus protecting the esophageal lining. The fundus is the dome-shaped superior portion of the stomach, which lies above the level of the cardia. It often contains a gas bubble that is visible on radiographic imaging. The body or corpus is the central and largest region of the stomach, primarily involved in the storage and mechanical digestion of ingested food through churning movements. The pylorus is the funnel-shaped distal part of the stomach, which includes the pyloric antrum and pyloric canal. The antrum is the wider portion where food is mixed with gastric secretions, while the canal narrows down and connects to the duodenum via the pyloric sphincter, a muscular valve that regulates gastric emptying. Curvatures and surfaces. The greater curvature is the longer, convex lateral border of the stomach that extends from the cardia to the pylorus. It provides attachment for the greater omentum, a significant peritoneal fold that drapes over the intestines. The lesser curvature is the shorter, concave medial border of the stomach. It serves as the site of attachment for the lesser omentum, which connects the stomach to the liver. The anterior surface of the stomach is related to the diaphragm, left lobe of the liver, and anterior abdominal wall. The posterior surface lies in close proximity to the pancreas, spleen, left kidney, and adrenal gland. These structures collectively form the stomach's bed, a term used to describe its posterior anatomical relations. Internal anatomy of the stomach, mucosal folds, rugae. Internally, the stomach is lined with mucosal folds, known as rugae. These folds are most prominent when the stomach is empty and serve to increase the organ's surface area. During food intake, they allow the stomach to expand significantly without increasing internal pressure. Gastric pits and glands. The surface mucosa of the stomach is punctuated by numerous invaginations called gastric pits. These pits lead into gastric glands, which are responsible for the secretion of various substances necessary for digestion, including acid, enzymes, mucus, and hormones. Histological layers of the stomach wall. Mucosa. The mucosa is the innermost layer of the stomach wall and consists of three components: the epithelium, lamina propria, and muscularis mucosae. The epithelium is made up of simple columnar cells that secrete mucus to protect the stomach lining from the harsh acidic environment. The lamina propria is a connective tissue layer that contains capillaries, lymph vessels, and immune cells. The muscularis mucosae is a thin layer of smooth muscle that aids in the movement of mucosa and helps expel glandular contents. Specialized cells found within the gastric glands include parietal cells, which secrete hydrochloric acid, HCl, and intrinsic factor, chief cells, which produce pepsinogen, mucous neck cells, which secrete mucus, and enteroendocrine G cells, which release the hormone gastrin. These cells play a pivotal role in the digestive processes occurring in the stomach. Submucosa. The submucosa is composed of dense connective tissue that houses larger blood vessels, lymphatics, and nerves. It provides structural support and contains the Meissner's plexus, a network of nerves that regulates secretions and local blood flow within the mucosa. Muscularis externa. The muscularis externa of the stomach is unique because it contains 3 layers of smooth muscle rather than the typical 2 found in most parts of the gastrointestinal tract. These layers are the inner oblique, middle circular, and outer longitudinal layers. Together, they allow for powerful churning and mixing movements, enhancing the mechanical digestion of food. Serosa, or visceral peritoneum. The outermost layer is the serosa, also known as the visceral peritoneum. It is a smooth membrane that covers the external surface of the stomach, reducing friction between the stomach and surrounding organs during movement. Gastric juices and secretions. Hydrochloric acid. Hydrochloric acid is secreted by the parietal cells and maintains the stomach's highly acidic environment, with a pH ranging from 1.5 to 3.5. This acid denatures dietary proteins, facilitates the activation of pepsinogen into pepsin, and destroys ingested pathogens, thereby playing a crucial role in both digestion and immunity. Pepsinogen, secreted by Chief cells, is an inactive enzyme that is converted into pepsin upon contact with hydrochloric acid. Pepsin is a protease that breaks down proteins into smaller peptides, initiating protein digestion in the stomach. Mucus. Mucus is produced by mucus cells and forms a protective barrier that coats the stomach lining. This barrier prevents the stomach from digesting itself and protects against the corrosive effects of hydrochloric acid and pepsin. Intrinsic factor. Intrinsic factor, also secreted by parietal cells, is essential for the absorption of vitamin B12 in the ileum. A deficiency in intrinsic factor leads to pernicious anemia, a condition characterized by impaired red blood cell production. Gastrin. Gastrin is a hormone released by G cells in the pyloric antrum. It stimulates gastric acid secretion, enhances gastric motility, and promotes the growth of the gastric mucosa. Gastrin release is triggered by the presence of peptides and amino acids in the stomach. Physiology of gastric function. Gastric motility. Gastric motility involves coordinated muscular contractions that facilitate the mechanical digestion and propulsion of food. It can be divided into 3 phases. Receptive relaxation occurs when the fundus and upper body of the stomach relax to accommodate incoming food. Peristaltic contractions begin in the body and move toward the pylorus, mixing the food with gastric secretions. Gastric emptying is regulated by the pyloric sphincter, which ensures that only small amounts of chyme enter the duodenum at a time. Gastric digestion. Digestion in the stomach involves both mechanical and chemical processes. Mechanically, the stomach churns food through peristaltic movements. Chemically, the acidic environment and enzymes like pepsin break down complex macromolecules into simpler forms, suitable for absorption in the small intestine. Gastric absorption. Although the stomach is not a primary site for nutrient absorption, certain substances such as alcohol, aspirin, and some water-soluble drugs can be absorbed directly through the gastric mucosa. Neuro-hormonal regulation of gastric function. Cephalic phase. The cephalic phase of gastric secretion is initiated by the sight, smell, taste, or thought of food. This phase is mediated by the vagus nerve and stimulates the secretion of gastric juices even before food enters the stomach. Gastric phase. The gastric phase begins when food reaches the stomach. It involves both mechanical stretch of the stomach wall and chemical stimulation by partially digested proteins. This phase leads to further stimulation of gastric secretions and motility. Intestinal phase. The intestinal phase starts when chyme enters the duodenum. Initially, it stimulates gastric activity, but subsequently inhibits it through mechanisms like the enterogastric reflex and the release of hormones such as secretin and cholecystokinin. These hormones reduce gastric secretions and slow gastric emptying to allow adequate digestion and absorption in the small intestine. Associated structures and blood supply. Blood supply. The stomach receives a rich blood supply primarily from branches of the celiac trunk. The left gastric artery supplies the lesser curvature, while the right gastric artery contributes to the same area from the hepatic artery. The right and left gastroepiploic arteries supply the greater curvature, and the short gastric arteries serve the fundus. Venous drainage parallels the arterial supply and ultimately drains into the portal vein, allowing nutrient-rich blood to pass through the liver for processing. Lymphatic drainage. Lymph from the stomach drains into the gastric and celiac lymph nodes. This pathway is clinically significant because gastric cancers often metastasize through these lymphatic channels. Innervation. The stomach is innervated by both the parasympathetic and sympathetic nervous systems. Parasympathetic innervation is provided by the vagus nerve, which enhances secretory and motor activity. Sympathetic fibers arise from the celiac plexus and serve to inhibit gastric activity and constrict blood vessels. Pathological considerations. Gastritis. Gastritis is the inflammation of the gastric mucosa and may be acute or chronic. Common causes include infection with Helicobacter pylori, prolonged use of NSAIDs, alcohol consumption, and stress. Peptic ulcer disease. Peptic ulcers are erosions in the mucosal lining of the stomach or duodenum, resulting from an imbalance between aggressive factors like acid and pepsin and protective mechanisms like mucus and bicarbonate. They are frequently associated with H. pylori infection and NSAID usage. Gastroesophageal reflux disease, GERD. GERD occurs when the lower esophageal sphincter fails to prevent the backflow of stomach contents into the esophagus, leading to symptoms such as heartburn and regurgitation. Gastric cancer. Gastric cancer often presents in advanced stages and is associated with risk factors such as chronic gastritis, H. pylori infection, smoking, and dietary habits. It commonly metastasizes to regional lymph nodes and distant organs. Gastroparesis. Gastroparesis is a condition characterized by delayed gastric emptying in the absence of any mechanical obstruction. It often results from vagus nerve dysfunction and is commonly seen in diabetic patients. Embryological development. The stomach originates from the embryonic foregut and undergoes significant morphological changes during development. Initially, it forms as a simple tubular structure that subsequently enlarges and rotates 90 degrees clockwise around its longitudinal axis. This rotation brings the left side of the stomach anteriorly and creates the greater and lesser curvatures. The differential growth of the dorsal and ventral walls contributes to its final J-shaped appearance. Stomach, in clinical imaging and endoscopy. The stomach can be examined using various diagnostic tools. X-ray imaging with barium contrast highlights the stomach's shape, position, and motility. Endoscopy allows direct visualization of the mucosa and facilitates biopsy for histological examination. CT and MRI scans are useful for evaluating structural abnormalities, tumors, and complications, such as perforation. The stomach is a sophisticated organ integrating anatomical architecture, enzymatic activity, and neuro-hormonal control to facilitate digestion. From its layered histology to dynamic motility and robust secretion, the stomach's design underscores its central role in gastrointestinal physiology. Understanding its complex structure and function is crucial, not only for academic knowledge, but also for diagnosing and managing various gastrointestinal disorders.